Hi, everyone. Thank you for joining us. We're going to give it another minute to allow everybody to log in, and we'll be with you shortly. Hi, good evening, everyone, or good afternoon, depending on where you're located. My name is Aviva Rosenberg. I'm the co-president and co-founder of Gaucher Community Alliance, and thank you for joining me for this webinar on Gaucher disease and bone health. And we have a great program for you this next coming hour. So I want to just take this opportunity to talk a little bit about some of our other upcoming events for Gaucher Community Alliance. So first of all, we have a Teen and Young Adult Day on Capitol Hill, June 24th to June 26th. Our teenagers and young adults from all over the country are coming to Washington, D.C. to advocate for rare disease research and Medicare home infusion. And so if you have someone in that age range and that you would like to join us on that trip, we are still taking registrations. And so we hope to have a very productive time on Capitol Hill. Our other upcoming in-person program is our Seattle meeting on September 14th. And so that is going to be for people out in the Washington State area. We will be having a lovely day program on Sunday, September 14th with lots of speakers and different types of wellness exercises. So if you're in that area, please join us there. And finally, I know it's only May, but October is Gaucher Awareness Month, which is a really great opportunity to have different fundraisers in your community to raise awareness. And so if you're interested in having an October Gaucher Awareness local fundraiser, please reach out to us at Gaucher Community Alliance, and we would love to work with you to develop something that's appropriate for your community. So with that, keep following us on our social media and Instagram, Facebook, LinkedIn, and of course, make sure you're signed up for our mailing list. It gives me a great pleasure to introduce our speaker tonight, Dr. Robbie Kamath. He is the head of musculoskeletal radiology at Fairfax Radiological Consultants and Innova Health System. They are located in Northern Virginia, just outside Washington, D.C. Dr. Kamath is also an assistant professor at University of Virginia School of Medicine. He received an MD from Harvard Medical School and a PhD in genetics at the University of Cambridge, followed by postdoctoral fellowships in the UK and US. He completed an internship in internal medicine at Brigham and Women's in Boston, followed by radiology residency and fellowship at Mass General. After completing his clinical training, Dr. Kamath was on faculty of Harvard Medical School before moving to his current practice. His interest in Gaucher disease began at Harvard nearly 20 years ago. Since then, he has been involved with several clinical trials examining the efficacy of new and existing treatments for Gaucher and has helped several countries set up centralized radiology services for the diagnosis and surveillance of Gaucher disease. In collaboration with local physicians, Dr. Kamath currently provides continuing care for a large cohort of Gaucher patients. So before I turn it over to Dr. Kamath, this is an interactive presentation. If you're able to answer questions through your smartphones, then that will be an opportunity for you. If you do not have a smartphone handy, if you prefer just to sit and listen, you will also enjoy this presentation immensely. Totally up to you. If you have questions during the presentation, please use the Q&A or the chat features, and there will be time at the end for Dr. Kamath to address some of those questions. So I hope you enjoy, and I'm going to turn it over now.
Okay, thank you for that introduction. Let me get this started here. Okay, so as Aviva said, today I'm going to talk about bone imaging and Gaucher disease, which I know is an important topic. These are my disclosures. And this is the brief agenda of what we're going to run through today. So again, this is me. Like she said, I'm a radiologist in Northern Virginia, just outside of Washington, D.C. and I've been working on Gaucher and with Gaucher patients for over 20 years now. As she stated, this is an interactive presentation. So if you would like to participate in the interactive features of the talk, you can just aim your smartphone camera at this QR code, and then you can use that to respond to some of the quiz and poll questions on the phone. There will also be some other QR codes that you can scan to get additional information that's related to the talk later on. So I'm just going to leave this up here for about 15 or 20 seconds, so anyone who wants to can scan this, and then we'll get started. Okay, so this is our first poll question. Again, there's the QR code that you can use if you haven't had a chance to join yet. So the first question is, how confident do you feel about your Gaucher disease bone health knowledge? So as people respond, then this will update live. And again, I'll give this maybe 30 seconds, 20 to 30 seconds for people to respond if they choose. And again, if you'd like to join, the QR code is still the one in the top left corner. Okay, good. So it sounds like people have varying degrees of confidence, but people feel like they know something. But I hope that by the end of the talk today, you'll have learned something more to contribute to your store of knowledge. So let's start by talking about the basics of Gaucher disease. So as you all know, Gaucher disease is a rare inherited condition that gets worse over time, and it can affect multiple parts of your body. In this particular talk, we're focusing on bone. There are three types of Gaucher disease, types 1, 2, and 3. Most of what I'm going to show you today is related to Gaucher type 1. The bone disease can often start silent, but it can be among the most debilitating long-term consequences of Gaucher disease, and therefore bone imaging is a critical tool for the management of patients who have Gaucher. And again, symptoms of Gaucher can run the gamut, but really today we're focusing on complications in bone and related bone pain. So how does Gaucher disease impact bone? Well, there are many different manifestations that it can take. At the most basic form, patients with Gaucher disease can present with bone pain. Sometimes this can be diffuse and generalized, and sometimes patients can have acute bone crises, which we'll talk a little bit more about later. Patients can develop pathologic fractures, which means that there's a normal force applied to bone, but because the underlying bone is abnormal, then the patient can develop a fracture through the bone. As a part of normal development, patients with Gaucher disease can have abnormal bone remodeling, such as a tubulation deformity, which results in the characteristic Erlenmeyer-Flask deformity in the femur that we see in Gaucher patients. Gaucheromas are tumor-like aggregates of Gaucher cells that can accumulate anywhere in the body, including in the bone, and they can cause tissue and bone damage. Patients with Gaucher can develop joint complications, which can just include pain, deformity of the joint, or damage related to the Gaucher disease. Sometimes this can be related to osteonecrosis, which is the death of bone, which can actually cause the joint to collapse, which can later require the placement of joint prosthesis. The patient, osteonecrosis can also take the form of bone infarcts, which occur away from the joints. Gaucher disease can also result in loss of bone mineral density, which is abbreviated BMD, and that can result in osteopenia or osteoporosis, which are basically varying degrees of severity of bone demineralization. And then finally, Gaucher cells can infiltrate the bone marrow and replace it with what's called dark marrow or infiltrating Gaucher cells. And again, these are all topics that we'll talk about in greater detail. So this is our next poll question. So general knowledge question. So how many of people with Gaucher disease, roughly what percentage of them have bone disease? So again, I'll give you about 20 seconds to respond to this question. So we'll let people respond, and then we can see the polling numbers on the next slide. Okay. So most people answered 82%, which is correct. and we'll talk a little bit more about that in a moment. So let's talk about bone imaging and its role in Gaucher disease. So there are three main types of imaging that we use in patients with Gaucher: X-ray, MRI, and DEXA, and we'll talk about each of these in turn. So let's start by talking about X-ray. So X-rays or radiography uses low levels of radiation to take pictures of the inside of the body, in this case, your bones. And X-rays are very good for finding fractures and other bone problems, and also for revealing changes in the bone, such as joint deformities. However, X-rays are not effective at looking at the bone marrow, at measuring strengths of bones, and they're not very good for detecting the very earliest signs of bone disease. So the good thing about X-ray is that it's very quick. So, the images themselves take a fraction of a second to obtain. And to obtain an X-ray multiple views usually takes maybe a minute or two. It's the least expensive, most widely available imaging test that we have, both domestically and in other countries. Offers the highest imaging resolution, and it's very good for an initial evaluation, assessing for fractures and bone lesions, and also for monitoring joint replacements. However, X-rays have a very low sensitivity for detecting early signs of Gaucher disease. By some estimates, X-rays can only detect about 30 to 40% of bone findings in Gaucher. It's also not very useful. In fact, it's not useful at all for assessing bone marrow, which I'll show you a little bit later. And it does expose patients to a low level of ionizing radiation. So what are some things that we can see when we look at the bones of patients with Gaucher? So fractures is something that we can identify. In this particular case, this is a patient's lumbar spine, so the lower back. And here you can see that there is one of the vertebrae, instead of having a normal rectangular shape, it has a more trapezoidal shape or wedge deformity. And so this is a fracture of one of the lumbar vertebrae. And the X-ray can show us that the fracture is there, but it can't tell us whether this is something new or whether it's something old. The Erlenmeyer-Flask deformity is a developmental deformity that can occur by a tubulation defect during development. And so as a result, instead of having this normal curved flaring of the end of the bone here and the distal end of your thigh bone, the lower thigh bone, you can see here it has this smooth tapering edges, which looks like an Erlenmeyer-Flask used in chemistry, which is where the name of this comes from. Bone lesions can also occur in patients with Gaucher from Gaucheromas, which deposit in bone and can actually cause destruction of the bone in the area where the Gaucher cells deposit. That manifests on X-ray as a dark area, which is caused by the lysis of bone. So it's actually destroying the bone and resulting in abnormal darkness in the bone, which you can see here. Osteonecrosis, which is the death of bone, can also occur. On X-ray, when it's pronounced, we can see it look like this, where there's a white rim of sclerosis around an area of what is essentially dead bone that looks darker. But sometimes, as I'll show you later, osteonecrosis can be very subtle and can be very difficult to detect on X-ray. X-ray is also good for looking at prostheses. So sometimes when patients develop severe bone disease and they can have joint collapse, which requires placement of a prosthesis, and X-ray is good for looking at those prostheses. This is an example of a patient who had both hips replaced. So this is the patient's left side, and this is the patient's right side. And this patient's right hip prosthesis has started to fail. So you can see normally that the prostheses consist of a metallic component with a plastic liner. And the plastic liner has started to erode, so you can see that this ball of the hip joint is not symmetrically located within the cup. And there's also areas of bone resorption here adjacent to the femoral component of the prosthesis. So this is an example of prosthesis failure and what's called particle disease. And so this patient will probably have to have a revision of that prosthesis. So MRI stands for magnetic resonance imaging. That's another very important tool that we use to monitor bone health in Gaucher. And MRI uses a strong magnetic field and radio waves to create images of tissues and bones in the body. MRI is very important for looking for bone marrow infiltration in Gaucher, which we typically look in the thigh bone, in the femur, and in the hip, and in the lower back or lumbar spine. MRI is much more sensitive than X-ray for detecting bone pathology in Gaucher, so it can detect changes in the bones much earlier than an X-ray. And it can be used over time to look for changes in the bone marrow signal. The good thing about MRI is it is the most sensitive test that we have for finding bone abnormalities, but also for finding soft tissue abnormalities as well in the liver and spleen. It allows for the earliest detection of bone issues of any kind. And it also has no exposure to ionizing radiation. So there's no radiation with MRI, unlike X-ray. However, that has a number of very important drawbacks. So the first is that it's an expensive test. The exam time is long. A typical MRI takes about 30 to 40 minutes for each one. So you can imagine that if you're having MRI exams of your abdomen and your lumbar spine and your femurs, as many Gaucher patients do, to get all of those together in one sitting can take an hour and a half or even more, depending upon the type of scan that you're having. And that can be difficult for people to stay still for that long. And MRI is not universally available. There are some places geographically within the US where it can be difficult to get. Some places you can get an MRI, but you have a long wait time. And then in some parts of the world, it's not even possible to get an MRI. There are some reasons why patients might not be able to get an MRI, because to get an MRI, you have to lie in an enclosed tube, typically for a long period of time. And so if you cannot do that for any reason, it can make it difficult for you to have an MRI. So for example, patients who have claustrophobia, which means fear of being in enclosed spaces, that can make it very difficult or impossible to have an MRI. Also, patients who cannot lie still on their back for long periods of time. For example, patients who have back pain, restless legs, Parkinson's disease with tremors, things like this can prevent patients from getting MRIs. Some patients, such as young children, may not be able to fully cooperate with the exam and stay still, and they may require sedation in order to have an MRI, which has its own risks. Finally, another thing not to be underestimated is that although X-rays are very, very easy for many different types of physicians to interpret, MRI requires a lot of expertise to interpret correctly. And in this case, it's not even just interpreting an MRI, but it's specifically understanding how to interpret an MRI in a patient with Gaucher who's familiar with the appearance of Gaucher on MRI and who knows what to look for. So that's another major drawback is the necessity to have someone who's an expert who can really interpret the images correctly. And then finally, in young patients especially, it can be difficult to distinguish dark marrow, which is marrow infiltrated with Gaucher disease, with Gaucher cells, from red or hematopoietic red marrow, which is the red marrow that generates red blood cells and other blood elements. And that's particularly true in young patients. And we'll talk a little bit more about that later. So when we look at MRI images, we typically talk about T1 and T2. Those are terms that you'll hear thrown around. And just to make things simple, T1 weighted images are good at looking at fat, such as bone marrow in adults, which is mostly comprised of fat. And T2 weighted sequences are good at looking at fluid. And fluid is commonly found where there's inflammation, infection, swelling, and tumors, which means most of the kind of abnormalities that we're looking for look bright on T2. So this is an example of some MRI images from patients with Gaucher disease. So here on the left side of the screen is a patient with mild bone involvement, and here on the right side of the screen is a patient with more severe involvement. These are T1 weighted images. So the normal background bone marrow looks like this. It's relatively white. And areas that are a little bit darker, as you can see here, are infiltrated with Gaucher cells. So this is dark marrow, but it's very mild in this patient. In contrast, you can see here on the right-hand side of the screen is a patient with much more severe involvement, where there are focal areas of dark signal, which could represent areas of marrow infarction or focal Gaucher cell deposition. And this patient also has osteonecrosis of the femoral head. I like this case because it also demonstrates one of the unusual features of Gaucher, which is that in some instances, the disease presentation, even in a single individual, can be very asymmetric. And that is one of the challenges for some of the scoring systems, as we'll describe later. This is, again, an example of patients with varying severity of Gaucher disease. Now we're looking at the lumbar spine and the lower back. So here's a patient with mild Gaucher disease. So there's dark marrow, but it's not that dark. Here's a patient with more severe disease. So I hope you can appreciate that this marrow is darker than this. That's because there's more infiltration with Gaucher cells in this patient. And finally, the patient on the far right has the most severe disease, where not only is the bone marrow diffusely infiltrated, but the vertebrae you can see have started to take on an unusual shape. So these are so-called H-shaped vertebrae, or some people call these codfish vertebrae because they almost look like fish. And this is a very severe manifestation of Gaucher disease in the spine. So this now we're looking at the ends of bone. So this is the lower part of the thigh bone, the femur, and then this is the knee joint. And one of the features of Gaucher disease that we've noticed over time is that dark marrow typically occurs in a very predictable pattern. So it occurs in some parts of the bone, but not in others. So in this case, you can see there's a clear delineation between the area of the bone that's infiltrated with Gaucher cells and the part that is not. And that is something that is very characteristic that we can see on MRI. And again, on MRI, you can also appreciate the abnormal morphology of the Erlenmeyer-Flask deformity in the distal femur. This is an example of a patient who has dark marrow that you can see very clearly on MRI, right, with areas of sparing that we talked about earlier. But you'll notice here, this is the same patient, and this is the X-ray in that patient. And there's really no clear delineation, for example, here between the area that's involved with Gaucher and the area that is not. The only finding that we can see here on this X-ray is that the patient does have some thinning of the cortex, but the actual signal of the bone or the density of the bone is not really that different in the different areas of involvement. And so therefore, you can't really use X-ray to assess for bone marrow changes. Osteonecrosis is also much better detected by MRI than by X-ray. Here's a patient who has osteonecrosis of the femoral head and the hip, which you can see here as an area, this kind of dark squiggly line, that's osteonecrosis or death of bone. And here on the X-ray in the same patient, I think maybe if you squint a little funny, maybe you can see it, but I think this would be something that would be very difficult to diagnose prospectively. So this, by definition, is the earliest stage of osteonecrosis, grade 1, where it's visible by MRI but not by X-ray. Here's an example of a patient with a bone lesion that I showed you earlier. So this bone lesion you can detect radiographically, where you see this hole in the bone here. But what's interesting is if you look at the MRI now, in fact, what you realize is the hole in the bone is actually this, where you see that there's a break in the cortex or the edge of the bone. And actually, the bone lesion is much more extensive than is visible in the MRI. It actually extends above and below where the hole is, and it involves the full width of the bone. So in fact, this lesion is much more at risk for pathologic fracture than it would be that it would indicate on the initial X-ray. And because of the appearance on the MRI, this is something where an orthopedist might want to treat this to make sure this patient doesn't develop a pathologic fracture. So the MRI does present a lot of useful information that we can't get from X-ray. So as I stated before, X-ray MRIs, because they take so long, sometimes they can make people feel anxious during the procedure. There are lots of techniques that people can use for getting through an MRI, and we have a take-home handout that I'll give you the QR code for later that provides some useful suggestions for that. So DEXA stands for dual energy X-ray absorptiometry, and X-ray is really the best test that we have for determining bone mineral density. Bone mineral density is abbreviated BMD. And BMD is a measure of bone strength, which can be used to predict the risk of developing bone fractures. And it can also assess for changes in bone density over time or response to therapy. And DEXA helps us to estimate the strength of bone, which is typically done in the proximal femur, which is at the hip, and also in the lumbar spine, which is in the lower back. In patients who, for whatever reason, cannot have scans done in those areas, then we can also look at the distal radius and ulna in the wrist. So the pros of DEX are that it's the best instrument that we have for measuring bone mineral density, and it is generally widely available. It can be used to estimate risk of fragility fracture, which is known from population-based studies done by the World Health Organization. But the cons are that it really only offers a global, not a structural look at bone mineral density. What DEXA does is it takes a picture and it calculates the density of bone in a particular geographic area, but it does not look at the structure of the bone. So for example, we know that the cortex of bone and the trabecula inside the center of the bone have different components that provide strength to the bone, and it doesn't really differentiate between those different components of bone. It can also be difficult to compare exams done on different machines. So if you go to one place to have a DEXA done one year, and then you go to a different place to have it done the next year, it will be very difficult and maybe not even possible to compare the results done on those two scanners. So generally, if you're getting DEXA, you should try to go to the same place every year so the results will be comparable to your prior exams. It does expose patients to ionizing radiation, although at very low levels, typically even lower than X-ray. And as I stated previously, it cannot be used in areas where patients have hardware or bone lesions. So if you have a hip prosthesis, then you cannot have DEXA in that area because it would measure the density of the prosthesis and not of the bone. Likewise, if you have a bone lesion or osteonecrosis in one of those areas, you cannot have DEXA in that area because it will confound the bone mineral density calculation. So this is what a DEXA report looks like. It's very busy. There's a lot of information on here. But the main reason why I want to show you this is just to show you this is what your doctor is looking at. And this is why doctors like DEXA, because there's a lot of numbers and a lot of data. And so it's not just, is it better or is it worse? But they can actually look at the actual bone mineral density in grams per cubic centimeter and then determine, what is the percentage change that you have over time. So this is something that's numeric and quantitative, and doctors really like that. So these are the major bone imaging tests used in Gaucher, just to summarize. Again, X-ray is good for many pathologies, but it's not as sensitive as MRI for many of those. MRI has a very special use looking at dark marrow, and it's really the only tool that we have to look at bone marrow infiltration. And then finally, DEXA has a specific use to look at bone mineral density. So now let's talk about some acute problems that can occur in the bones related to Gaucher. So imaging is an important tool to help your doctor understand what could be the cause of your bone pain. It's important to note that as Gaucher disease progresses, if bone problems are unmanaged, they can develop into more severe complications, some of which are irreversible. And so as a result, it's important for your doctor to understand what's causing your pain to make sure that you don't develop these severe and potentially irreversible complications. So let's look at some of these things. So this is a patient now looking at the upper part of the back, which is the thoracic spine. And this patient has developed, as we can see here in the X-ray, compression fractures. So you see the vertebra has these vertebrae here and here have lost height, so they've become compressed. But again, from the X-ray, we don't know whether this is something acute or new, or if it's an old or chronic problem. And here, now we get an MRI on that patient, and we can see that there's this bright signal in the bone. This is a T2 weighted sequence, so that bright signal indicates that there's edema or inflammation in the bone, which is suggestive of a new or acute problem. So this is potentially the cause of the patient's pain. This is a patient who has a focal lytic bone lesion from Gaucher cells, and then the patient developed a pathologic fracture through this bone lesion. And so X-ray is very good for looking at both bone lesions and pathologic fractures. Sometimes when patients have low bone mineral density, they're given medications called bisphosphonates, which can help to improve bone mineral density. But one of the unfortunate side effects of bisphosphonates is that they can cause a very specific type of fracture, which are called atypical femur fractures, because they occur at an unusual location, which is here in the upper part of the thigh bone. And this is an example where I think it's very obvious here, this is the patient's right side. So the patient's right proximal femur is fractured. But if you look here on the left side, you can see that the cortex here is also buckled. The cortex of the bone is a little thick. And so this is a potential impending fracture on the other side as well. And so this fracture will definitely need to be fixed. And the orthopedist might at the same time decide to fix this one just to make sure the patient does not develop that kind of fracture on the other side. Osteonecrosis, also called avascular necrosis or death of bone, is something that is readily apparent on MRI. This is a T1 weighted image. And again, here, just like on the other one that we showed earlier, you can see these areas of geographic dark signal on the T1 weighted image here in both hips, which is osteonecrosis. Now, again, if you look at the X-ray, I think on this one, it's a little more apparent than on the last example that I showed you, but it's still very difficult to see. But the thing that gives it away on the X-ray is the fact that if you look at this femoral head, you see how it's very smooth and curved. But on this one, it almost looks like there's a point here. And then here, this part is flattened. So this is an example of articular surface collapse, which is one of the dreaded complications of Gaucher. This is in the very early phase. But over time, as that bone gets weaker, then this femoral head articular surface can collapse and can fragment, which can cause a lot of pain and can eventually destroy the joint and require the need for a hip replacement. So it's worth noting that this is something that we saw a lot of a long time ago when they were commonly doing splenectomies in patients. But in more recent younger patients, I would say this is a less common phenomenon. So another form of osteonecrosis is when it occurs away from the joint. So that's called marrow infarction, but it's physiologically the same process. And you can see it here much more apparent than on the other slide that I showed you, with this white area outlining the areas of bone death, both in the end of the femur and also in the upper part of the tibia or the lower leg bone. But again, just like for the fracture, you don't know if this is an acute problem or if it's a chronic problem. But when you do the MRI, you can see, for example, there's one area here that has bright signal on the T2 weighted sequence, which is showing you that there's inflammation associated with this bone lesion. There are some areas in this patient that are chronic, as in the upper tibia, And there's some areas that are acute, as in the lower femur. So we talked about bone crisis. Sometimes when patients have bone crisis and we do an MRI, we can see this, which is this abnormal bright signal in the bone on the T2 weighted sequence. And sometimes patients also have a joint effusion, so reactive fluid in the joint. And this is one of the manifestations of acute bone crisis. But it's worth noting that although we can see abnormalities on MRI sometimes, oftentimes the imaging can look completely normal, even on MRI. And a bone crisis is an episode of acute severe bone pain that may or may not be accompanied by fever, and they can occur in about 1 out of every 3 patients with Gaucher disease. And the problem is that these acute bone crises can be difficult to distinguish from other problems that can be treated. So, for example, fractures, osteonecrosis, or even infection. And so it's really important that your doctor pays a lot of attention to that to determine whether it's one of these potentially irreversible causes or treatable causes versus something that will go away on its own. So bone pain in Gaucher is very challenging. Patients who have Gaucher disease can have all these complications that we've shown, but they can also have bone or joint pain that's not related to Gaucher, just like anyone else. And to help your doctor understand your pain, it's important to think about the kind of pain you're having. Is it widespread or just in a certain part of your body? Is it the bone pain that you're having now different from the pain you've experienced in the past? And those are the questions that when discussing them with your doctor will help to determine whether you need imaging at all. When imaging is done, typically x-rays are helpful as a first look when bone pain happens. And if the pain persists or if it's particularly concerning for some reason, then more advanced imaging techniques such as MRI may be needed. Okay, so this is a quiz. So how many untreated patients or what fraction of untreated patients with Gaucher disease will experience a bone crisis? So again, I'll give you about 20 seconds to register your answers. Okay. So yes, the correct answer is 1/3. So about 1 out of every 3 patients, untreated patients, will develop a bone crisis. Okay, so now we're going to talk a little bit about bone imaging scores. So I know that this is a point of confusion, so I thought it's worth spending a little bit of time about these so that we understand what they mean. So let's start about talking about the bone marrow burden score. So the idea of the bone marrow burden score is that you have a complicated set of images like an MRI, and the idea is to condense all the information on that MRI into a number. So you can understand how that idea is very compelling because we understand numbers and we can understand, that an 8 is bigger than a 4, for example, and then we understand that a patient with an 8 has more severe disease than a patient with 4. Whereas trying to describe those things qualitatively is much more complex and takes a lot more time. And so the bone marrow infiltration, because we know that bone marrow infiltration is an important parameter of disease severity that can only be seen on MRI, then the bone marrow burden score is something that could potentially be useful as a reflection of patients' bone health. So the way it's done is MRI scans of the spine and femur are performed, and those images are scored from 0, which is normal, to 16, which is the most severe disease. And it's important to note that although the scores are numerical, they are not proportional. So in the example I used earlier, for example, a patient who has a bone marrow burden score of 8 does not have disease that's twice as severe as a patient with a score of 4. All that we can say is that a patient with a score of 8 has more severe disease than a patient with a score of 4. And sometimes patients who can have the same score, for example, 2 patients who have a score of 8, one might in fact have more severe disease than the other. So there's a value to having the qualitative statement that, okay, this bone marrow looks like it's improving, for example, in one patient. But the area where the bone marrow burden score can particularly be helpful is in epidemiologic studies or large scale clinical trials. So the bone marrow burden score is useful because it includes not just a visual interpretation of the bone marrow signal, but also the location of the signal abnormality. So how does this work? So here's an example of 2 sets of images from the same patient with Gaucher. This is the same patient I showed you earlier. This image on the left side of the screen is the T1 weighted image, and the one on the right side of the screen is the T2 weighted image. And so we look at the signal in the bone on the T1 weighted image, and you can see there's a little bit of dark marrow. It's a little bit darker than the background bone marrow, but not much. So the T1 score is slightly hypointense. The patient gets 1 point for that. Then we look at the T2, and again, it's a little bit darker than the background bone marrow. So they get a slightly hypointense on the T2. They get a point for that. And then it's scored based on the location. So this is really only located in the central part of the bone. It's not located at the ends of the bone, which are typically only infiltrated with more severe disease. And so this gets a 1 score for location. So you add 1, 1, and 1, and you get a score of 3 for the femurs. Here is the bone marrow burden score in the lumbar spine. So again, this is a T1 and T2 weighted images. And so we look at on the T2, which is here, we compare the signal in the vertebra to the subcutaneous fat here. And we can see that obviously this is darker than this. So the patient gets a score of 2 for the T2. And we look at the T1 and we compare the signal here to the adjacent intervertebral disc. And here it looks like maybe it's about the same. So the patient gets a point for that. And then the infiltration is diffuse, except for sparing of fat adjacent to the basivertebral vein. So the patient has diffuse involvement, and so they get 2 points for that, but they do not get the point for infiltration adjacent to the vein. So you add the 2 and the 1 and the 2, and the patient gets 5 for the spine. So you add the 3 and the 5, and you get a total score of 8, again, with 0 being normal and 16 being the most severe. So this is a patient who has, I would say, relatively more severe involvement in the spine than in the femur, which is reflected in the score. So bone marrow burden scoring in children is very complicated. So in the original paper that described the bone marrow burden score, they, in principle, validated this for use in patients ranging in age from 12 to 71. But it's important to note that in children, children typically have a lot of red marrow, which is bone marrow that is still actively producing blood cells. And that bone marrow can look indistinguishable from dark marrow on MRI. And so therefore, it can be very difficult to determine how much of the abnormal bone marrow signal that you're seeing in children is dark marrow and how much of it is red marrow, which is just a normal physiologic process. And so that's something that can confound our ability to determine the bone marrow burden score, or just in general, the amount of dark marrow infiltration in children and even in young adults. So we just got done talking about the bone marrow burden score, which is an MRI-based scoring system, abbreviated BMB. Now we're going to talk about a different way to measure bone health, which is BMD, or bone mineral density. It's a completely different thing. So the bone mineral density is, again, used to determine how much bone structure you have, the density of your bones. And this is typically done using DEXA. And there are two main scores that are used for the bone mineral density measurements. One is the T score and one is the Z score. So the T score compares the bone mineral density of a patient with the average bone density of a young, healthy adult of the same sex, so someone with peak bone mass. So if you think about the time in your life when you had absolutely as much bone as you're going to have, which is typically for a female in the early 20s, like around 24, and for a male, maybe a little bit younger, then it's how much bone you have compared to a person who has the absolute most amount of bone that you'll have in your life. And so the categories for the T score are determined by how many standard deviations below normal you are. So anyone who's within 1 standard deviation is considered normal. If you're between 1 and 2.5 standard deviations below, that's considered osteopenia or low bone mass. And osteoporosis is anything that's less than 2.5 standard deviations. These are the categories that were defined by the WHO. And these can be used to predict fracture risk in patients. Now, it's worthwhile noting that this is done. The idea of this is to determine fragility risk in postmenopausal females, and it's not necessarily done to predict fragility, fracture, and Gaucher disease, but it's been sort of extrapolated to that. The other score that we use is something that is maybe more useful in Gaucher, which is called the Z score. So the Z score compares a person's bone mineral density with someone else of the same age, sex, and body size. So this is comparing you to another person of your same demographic, and then determining how far below that you are for a person who's sort of the same stage of life that you are. And that's particularly useful for, let's just take an example, like in a child or a teenager, right? These are people who have not yet reached peak bone mass. So it would not make sense to discuss their bone mineral density in terms of T score because they've not had the opportunity to develop peak bone mass yet. Instead, if we compare a child to another child of the same age, that will more accurately determine where that child is in terms of their bone mineral density. So the z-score is typically defined as, more than 2 standard deviations below normal is essentially normal. And if you're two standard deviations or more below normal, then that is considered abnormal. Okay, so here's another Quizlet. So DEXA scans are used too, and then here are your options. So again, I'll give people about 20 seconds to answer this. Okay, so that's good. Yeah, so it's DEXA is the best test to look for osteoporosis and fragility fracture. Determining overall bone health and bone mineral filtration is better done by MRI. And looking for osteonecrosis, lesions, and other both bone features can be done by radiography or by MRI. Okay, so let's recap. So the International Collaborative Gaucher Group set forth these recommendations for imaging surveillance in bone. So for patients not on therapy, they recommend getting some sort of imaging roughly every 12 to 24 months. For patients who are on therapy but have not yet achieved their therapeutic goals, it's recommended once every year. And once those patients have achieved therapeutic goals, then you can start to stretch that out to every 1 to 2 years. Of course, if a patient has a change in medication or a significant clinical complication, then the imaging may need to be done at more at shorter intervals. And so again, these are just general recommendations, but really the imaging for each patient should be determined by the patient and the doctor collaboratively to determine what is appropriate given an individual patient's needs. So this is Care Connect is an organization that provides patient education and support. So this is a QR code that you can find out more information about Care Connect. And this QR code is also on the take-home handout that we have. And so I'm not going to stay here for too long, but if anyone wants to load that up, you can do that right now. So takeaway points. So bone disease affects the vast majority of people with Gaucher, we said around 82% by some estimates, and can significantly impact quality of life. Unmanaged bone disease can result in different types of complications like fractures, bone crisis, and bone death or osteonecrosis, and some of those are irreversible. Bone imaging is a critical tool for the management of Gaucher disease. The main imaging techniques that we use are X-ray, MRI, and DEXA, and each of those has different roles in the diagnosis and surveillance of Gaucher. DEXA is specially used for determining bone mineral density, and MRI can be used to determine dark marrow infiltration, which can also guide response to therapy and disease management. So what can you do? So you can visit your doctor to discuss imaging and other assessments that you may have had and you may need. You can work with your doctor to create goals for your bone health that help to preserve your health and mobility. And you can make questions for your doctor, do your research and talk to other patients and caregivers and come up with a plan. So this is the QR code at the bottom that you can that you can use to access a leave behind summary of this presentation. And I'm happy to take any questions.
Thank you very much. That I also, for those that don't have the QR code in the chat, I put the same link. So if you want a summary of the presentation, it's in the chat. And this is also going to be recorded and it'll be up on our website as well. So if you want to come back to it. I will open it for questions. I have a couple questions already, but feel free either in the chat or the Q&A if you have any questions. So maybe if you want to take down the shared screen, Dr. Kamath, and we can do some
Okay.
questions. So let's see. So is there a way to tell whether occasional neck pain is from scoliosis, stress, posture, or from Gaucher?
So I would say, I guess it depends. So if from obviously so scoliosis and just generalized neck pain from like muscle cramps and things like that, then those are things that you could potentially treat topically. For example, if you use heating pads and things like that, then that can help to assuage your pain. Probably that's coming from a more like a musculoskeletal cause rather than from like a deep bone pain. Again, if that's something that's unusual for you, that it's out of the character of your normal pain, then that's the time at which you want to bring it up with your doctor and potentially think about getting some imaging, whether it be X-rays or MRI.
Um, so can bone marrow involvement increase even after years of successful treatment?
Yes. So we do see that. I would say it's not typical. Oftentimes patients when they're on therapy and the therapy is working for them, then what we see is every year they come back and their bone is pretty stable. But we do have some patients in whom the bone is stable for long periods of time, and then for whatever reason, they could start to develop worsening complications. And that there are a number of reasons for that. Some are that, as we get older, we start to have other health problems, and sometimes that can cause our background medical problems to become sort of destabilized, and that can maybe cause some flaring of the issues related to your Gaucher. So yes, we do see that sometimes. So it's something to be aware of, and that's why it's really important to sort of be in tune with your body. And if you feel like there's something that's not right, then bring it up with your doctor.
Thanks. So how important is it to use the same imaging facilities over the years? I mean, I know that you talked about DEXA and the importance, but what about like MRIs or the other types of imaging? Can you talk a little bit about like going to the same place or moving around?
I think it can be helpful to do it on the same scanner. So as you guys probably know, their MRI scanners come in different flavors, right? So there are different when they talk about MRIs, there's something called the Tesla, which is the magnetic field strength of the scanner. And so scanners come in different magnetic field strengths, which can affect the way that the images look. And so if you get a scan done on a different scanner, that can cause a change. But I would say the bigger change is that when people do these MRI images, I mean, we talk about T1 and T2, but they're actually different amounts of T1 and T2, if that makes any sense. And so the way that it's how weighted it is can affect the way that it looks. And so I would say that in general, you can compare from one to another, but there are some instances in which it can be a little bit difficult. So if you can go to a place, then I would say it's probably better to go to the same place. But in my opinion, the most important thing is not so much the scanner, but it's more the person who's reading the scan. And so I would think that if you can go to a place with a person who knows what they're doing, looking at images from patients with Gaucher, that would be the best thing, regardless of where the scan was done.
Thank you. How common is a fracture in an area of a lytic lesion? I'm probably saying that wrong. And how well would such a fracture heal?
So the risk of fracture from a lytic lesion depends on how big the lesion is. So sometimes we can have lesions that almost completely destroy the bone, and when that happens, then that lesion is extremely high risk. Sometimes they're very small. You can't even see them on the X-ray. You can only see them on the MRI, and then those for that the risk is very low. So the bigger it is, and the more, if you can imagine like the bone, like in cross-sectional area, the more of the cross-sectional area of the bone that it occupies, the bigger a risk that it is. And yes, you are absolutely right that when you get a pathologic fracture through a bone lesion, it tends not to heal as well because there's something there which is not normal bone, right? So normal bone, if you break it, it will heal because the bone has reparative properties. But if there's something there like a Gaucheroma, then the Gaucheroma cells don't have that same reparative property as bone, so it will prevent the bone from healing normally. And so oftentimes when you have a pathologic fracture, that might require an orthopedist to treat it and put in a rod in order to basically facilitate the healing. Whereas if you didn't have a bone lesion there, you might not need that.
Okay. If someone is unable to get MRIs due to implants, would you recommend a PET scan or a CT scan?
Um, so the problem is that a CT scan or even a PET scan, they don't really show you the things that we're looking for, right? So we're really looking at bone marrow infiltration with Gaucher. So, I guess I would say it depends on what the implant is. So there are some things, for example, let's say that you have a hip replacement, right? A hip replacement would make it difficult to get an MRI of it in the hip area. I mean, you can have it because the concerns from MRI are from the magnetic properties doing something to whatever this implant is that you have, and to the fact that it heats up or could move, right? If you have a hip implant, a hip prosthesis, none of those are really a concern. You're not concerned about it moving. You're not really concerned about heating up, and it's not going to do anything. So although it obscures the area around where the implant is, the rest of the bone you can still look at. So a hip prosthesis, for example, is not a contraindication to getting an MRI. And in fact, sometimes we do MRIs on purpose to look at hip implants. But if you have something, for example, a pacemaker or an aneurysm clip in your brain or something like that, that is a real legitimate contraindication, then unfortunately, I think that CT, I mean, CT can give you some information. DEXA can give you, sorry, a PET can give you some information, but it's not the same kind of information that we get with MRI. And so I would say that it's generally not considered an alternative to looking at bone marrow infiltration, for example, because MRI is really uniquely suited for that purpose.
Thank you. That makes sense. DEXA, can you speak about DEXA results using functional height due to scoliosis versus actual height would be inaccurate? And what is that? I'm not sure if do you understand
Yeah,
it?
so I think the idea is that if you're scoliotic, right, then your spine is curved. So you're basically losing some height, some of your vertical height because it's basically going outward. And so then your DEXA results, which are partially so your Z score, which is based on your size, is going to be affected potentially by your by a difference in height. So I mean, I think that those things can cause a little bit of alteration in the score. But again, what we're looking at for the DEXA is more about changes in time, right? Looking at whether your medication is doing a good job of helping you preserve your bone mineral density, number one. And then number two, like a broad risk stratification. So is that change in height enough that it's going to actually push you from one category to another? And I think in most cases, the answer to that is probably no. So, I mean, DEXA, again, you have to understand you're kind of looking at things with broad strokes here in the first place. You're just really looking at, the density of bone overall. And so I think in most cases, it's probably not going to make that much of a difference.
Thank you. All right, so this is some recommendation questions. What recommendations do you have for perimenopausal and menopausal women to maintain their bone health?
So I think it's just like you see it in the news every day, right? The things that you need to do, exercise, diet, it's all the things that they're not necessarily that difficult to do in principle, but in practice they're very challenging. But I think the exercise and strength training in particular are very good for maintaining bone health. Making sure that you have a diet with adequate nutrition is very, very important. I would say that those are probably the two most important things. Someone else in the chat I saw had mentioned specifically about bisphosphonates. Bisphosphonates. So I showed you a bad complication for bisphosphonates. That doesn't mean that you shouldn't take them. That's a conversation to have with your doctor. But bisphosphonates can help people who are at risk for fragility fractures, and the risk of fragility fracture in general is higher than the risk of having an atypical femur fracture. Otherwise, they wouldn't prescribe it for you. And so, so that's another thing to consider. So there are medications that you can use, but I think, just like in many other things in life and health, diet and exercise are often the most important. These are different medications that can be used
Okay.
to basically increase bone mineral density. We do see improvements with those medications. I'm not, honestly, I'm not super well versed in the clinical trials that they use to look at those, but that, they're publicly available that you can look and see with the different brands of medications. But we do see some improvement in bone mineral density. But again, I mean, we do what we can, and I think the low hanging fruit is the diet and exercise, and then beyond that, then you can start looking at medications of different sorts. And again, which type of medication is appropriate for you would depend on your personal situation. It's a conversation you'd have with your doctor.
Got it. And what any thoughts on biphosphonates for children that have, low density due to Gaucher disease?
It's the same thing. I mean, again, there are risks and there are benefits. In kids in particular, you really want, because essentially once you hit your 20s, that's like as much bone as you're going to have generally, and then it only goes downhill from there. And so yeah, so it's kind of, the thought is, in children, it's especially important to encourage them to develop as much peak bone mass as possible. And so again, I'm not an endocrinologist or metabolic specialist, but that's the kind of thing that they look at and think about very, very carefully before prescribing that medication.
There's this question, which I'm maybe you can explain to us what it means, but the question is, are there any centers using HRPQCT for clinical evaluation versus using that for research? So maybe you could just tell the rest of us what exactly
Sure.
what
So
that means first.
HRPQCT stands for high resolution peripheral quantitative CT. And so what that is it's another way of looking at bone mineral density. So I talked about DEXA, and one of the weaknesses of DEXA is that it just offers this global look at bone. It doesn't look at the actual structure of bone. So HRPQCT is it's a small CAT scanner that basically looks at the bones. Often they do it in your wrist, and they look at the actual structure of the bone. So, looking at the little trabeculae in bone and the cortex of the bone, how thick is the cortex? And what percent of your trabeculae are still intact, because what happens is they get slowly resorbed, and you can sort of think of the trabeculae and bone as almost like a mesh, and it almost looks like someone came with scissors and like cut out pieces of the mesh as your bone gets demineralized. And so it can actually quantify that, and again provide you with a number, kind of like DEXA. Um, there are yeah, this I would say at this point, for all intents and purposes, that is essentially a research tool. There are various reasons why you wouldn't necessarily want to do a lot of that. It is CT, which has a much, much higher level of ionizing radiation. And so as a screening test, you have to sort of take a risk benefit analysis, right? So we use CT to screen patients, for example, who are at high risk for lung cancer, right? So you're talking about something which the radiation from CT being a low risk versus lung cancer, which is potentially something that could be, very catastrophic if you have it. And so, whereas with this, it's more of a screening test looking for something for which we already kind of have a test which is pretty good. It's not great, but we have a test which is like pretty good for it. And so the question is, what's the marginal benefit that's offered with the amount of radiation that you're getting? And so with that calculus, unless there's a specific reason why they're particularly attuned to that feature of your bone, then there's probably not a need for that. So people wouldn't necessarily widely recommend that. But that's something which is in for research purposes, it's something that's very interesting to look at how the bone remodels with Gaucher and with other diseases. Yeah.
Great. I have one last question. Over the years, since all of us have had many MRIs, sometimes the doctor will order a dye on top of the MRI. And so I'm kind of wondering when would that like why would you have an MRI with dye versus not? What specifically are they looking for?
So for Gaucher disease in general, like for the surveillance scans that we get, you don't need the dye. So just so everyone knows, so the dye that you get for MRI is called gadolinium, right? And gadolinium it's a naturally occurring element. It's one of like on the periodic table, it's one of those two little bars at the very bottom. It's one of those. It's like a rare earth metal. Okay. And what it does is it changes the magnetic properties of the tissues that you're in, and so that it's in. And so it kind of like lights up on the MRI. And it's particularly useful for looking for areas of acute pathology. And what I mean by that is it's areas that have a lot of blood flow to them. So the gadolinium will preferentially flow to those areas, and it'll leak from the small blood vessels into the soft tissues. And so that will cause those tissues to light up. Okay. And that typically occurs where there are, for example, tumors, inflammation, infection. That's the kind of spectrum of things that we're looking at. So for conventional imaging in Gaucher for surveillance, you don't need that. You don't need it to see bone marrow. You don't need it to see the liver or spleen size. And for generally speaking, you don't need to look for fractures either. The time when you might need that, for example, just in Gaucher, for example, is if you had a bone lesion, a lytic bone lesion that you can see on an X-ray, and your doctor wants to understand, what is this bone lesion? Because sometimes you can develop cysts in your bone that can kind of look like that too. And your doctor wants to know, is this lesion in the bone, is it solid or is it cystic? Is it something that looks like a Gaucheroma where it kind of has like a homogeneous look to it because it's all this Gaucher cells versus something that's like a bone tumor, like a metastasis or something like that, where it would have a different look to it on the MRI. And so that's the time when the contrast would be helpful. Another example in Gaucher would be if you had a patient who presented with hip pain and a fever, right? So this is a situation where, okay, does this patient have a bone crisis or does the patient have an infection like septic arthritis and osteomyelitis. And so that's another example where you might give the dye in order to help you distinguish between those things. And so there are some instances in which you need those, but generally speaking, it would be to address a specific acute issue and not just generally to look at Gaucher.
Okay, great. Well, thank you so much. We are at the hour, and I think we that was a whirlwind of questions. So I really appreciate you staying on, and to everyone that logged on tonight, thank you very much. And if you have any additional questions, you can reach out to me, and stay tuned for upcoming programs. And have a good evening. Thank you.
Great. Thank you all.